Here is a patient where you can see we've got some hemorrhage back in that area between those two occlusal surfaces on the mandible, between the first molar and the second molar. And radiographically, this is the depiction of that lesion. If you look at this level of bone here, you can see that we've got the marginal bone compromised to this point, but we've also got a defect that's deeper than that marginal bone, and actually almost 90% or so of that bone on that distal aspect of that distal root has been lost. We can also see that we've gotten progression to the furcation, and we've got that alteration in density of the bone here. So we've lost at least 40% of the inorganic portion of the bone adjacent to this area as well. So one of the factors involved with the development of this lesion is this crowding, in addition to the cup-like anatomy here that retains the plaque. So if we remove this tooth, we remove part of the original reason why that lesion developed. So in all cases, when we have this pathology back here, removing this second molar, which is not a highly functional tooth, is the way to approach the initiation of treatment, so that we remove part of the offending factors, and then we can progress to trying to grow new tissue adjacent to this root in order to save that functional tooth that we'd like to retain. So here is that marginal bone level that we just saw on X-ray, and down in this bone is the defect. So we use that same instrument, the periodontal curette, to remove all that granulation tissue out of that defect. We do our root planing, and we do a similar procedure to the subgingival curettage, where we're removing that granulation tissue, but now it's not just adjacent to the tissue, it's down in this defect. So once that's removed, what we've done by using that periodontal curette against that root dentin surface that's pretty profound as far as volume of surface area goes, we'd like to try to eliminate what has happened in the process. And what happens is that the dentin we're scraping away gets partially injected into those dental tubules and blocks them and decreases the surface area. So when we're looking at trying to repopulate that dentin with new cementum, which is the first material we'd like to grow on adjacent to that tooth and that defect, we'd like to have as much surface area for those cementoblasts to populate as possible. So we can use this EDTA 17% solution for 4 minutes adjacent to the tooth root and allow that to sit and then rinse it off. And what that's going to do is going to rinse away all of that mud, that dentin mud and debris that we packed into those little tubules. So this is an inorganic solvent, and that's what allows it to remove those calcium and phosphate remnants of that dentin dust that we've packed in there. So once that's done, we can place a bone graft. This is Consul, which is approved for use in dogs and cats for this purpose. And you can see it's placed at above the level of the marginal bone, and there's a reason for that. We don't want it to settle and go below the level. So we place it a little bit with the positive meniscus here, a little bit above the level of the marginal bone. And this is what it looks like. It's actually a silicate glass. It's a bioglass that's an osteoconductive bone graft, which means it provides a matrix for bone cells to populate and increases the surface area in the defect so that the osteoblasts can start to reside on those little glass particles and grow new bone. Synergy is another compound. This is tricalcium phosphate and hydroxyapatite, and it works quite the same way.